for today's live webinar, X-ray insights into the lower respiratory tract infection. So lower respiratory tract infection is one of the most common and challenging clinical practice encountered in the practice. So timely diagnosis and effective management are crucial, and chest X-ray remains the valuable and widely used tool in evaluating these cases. So to guide us through this important topic, we are privileged to have with us Dr. Prashant uh, Chajed, a highly respected pulmonologist, a consultant interventional pulmonologist at Center of Chest and Respiratory Diseases, Pulmonary Function Testing Unit, Asthma and Allergy Unit at Nanavati and Max Super Specialty Hospital, Mumbai. So, sir is affiliated with leading hospital including Fortis, Hiranandani Hospital, Nanavati Hospital, Lilavati Hospital, as well as his own lung care and sleep center study center. He holds an MBBS and MD in tuberculosis and chest diseases and DNB in respiratory diseases. So early in his career, he completed fellowship in respiratory medicine, lung transplantation, and thoracic medicine at institutions in Australia, Japan, and Switzerland. Sir specialties include bronchoscopy, pleuroscopy, intervention pulmonology, and management of sleep disorders, including sleep apnea, obstructive airway diseases, lung transplantation, and interstitial lung diseases. Sir is known for his strong research track record, having published over more than 150 peer-reviewed paper and presented extensively at various national as well as international forums. Sir has been a past secretary of European Association of Bronchology and Interventional Pulmonology from 2006 to 2010. And Sir is an active member of various national as well as international organizations and serves on the program committee and the planning committee of Clinical Problems Assembly of American Thoracic Society. And he serves as a chairperson of Indian Chest Society from 2013 to 2017. And he was elected on the governing body of Indian Chest Society from 2017 to 2019. So, very warm welcome to Sir, and we look forward for engaging and informative session. And we encourage all the audience to put their question on the chat box. So we will take this question at the end of the session. Now I hand over session to Dr. Prashant sir. Over to you, sir.
So thank you, Dr. Nishikant. That was a very generous and kind introduction. Yeah. So is my, I hope my,
Yes, sir. Your screen is visible. Yeah.
is visible. Perfect. Is it visible? I can't
Yes.
see.
Yeah.
Yeah, my screen is visible. Perfect. So I think today, I think the topic is a very common topic that we see in our daily practice, and it is something which we have to understand. Our understanding keeps on evolving. So we've got a very interesting case here, a case which is commonly seen in practice, and I'm sure most of you will relate to that case. Let's start. Sorry. I think I have to stop share because the slide is not moving. Just give me a minute. This is unusual. I think I think the tech support should not interfere. I think just let me do it my way, please. Yeah.
So tech support is not doing
Yeah.
anything.
Okay.
Ashish, can you just see what is the problem?
No, I will just see. I mean, normally they should work very
No problem, sir.
simply.
Maybe.
I'm not sure the slide should go forward. I'm not sure.
Simply click on a slide and use the arrow key.
But this is something we do every day. Not sure what is the problem.
So you can just click on the down arrow key.
Yeah, I'm clicking there.
Sir, share on the
Let me
full
check again.
screen. Full screen. Share
Yeah.
your entire screen.
Yes, that is what I've done. एक minute रुक जाइए. But let me see. Just wait for a second. Is it visible now?
Yes, sir.
Because we just checked this some time ago. Now is it visible?
Yes, sir.
Yeah, now there's
Yeah.
perfect.
Perfect. Okay, sir. So meanwhile, I encourage audience to put their question related to the case and as well as the topic in the comment box. We will take all the questions. Yeah.
So I'm not sure what has happened here. I think Dr. Nishikant, when you
Yes,
start
sir.
speaking, my slide is going off. Not sure what is wrong here.
Okay.
Yeah.
So,
My screen visible?
yes, sir.
Now
Visible.
it's not moving again.
Sir, share your entire screen. That will be.
Yeah.
Yes, sir.
And everything is screen. Everything is
Yeah,
shared.
yeah.
Not sure what's the problem.
So if it is a problem, you can just share the slide deck and we'll change it for you.
No.
Have you made any changes, sir?
Yes, I have made changes. Yeah, let me do it. I think my request is that the what do you call the authority should just be given to me. Yeah, if you can.
It's
Yeah,
with you, sir. It's with you.
perfect. Let's do this again.
Tech team make Prasant sir as an host.
Yeah, I think that is important. Yeah, not sure what is happening.
Make sir host immediately.
Done, sir. Done. Done, sir.
Done, sir. Now you can easily share.
Yeah. Yeah. Okay. Perfect.
Visible,
Yes.
sir.
So now I think
Perfect.
everybody shuts off. Yeah, please. We don't want any problems. Thank you. So now again, today we are just going to discuss about a very simple case. We're going to use this case just to, again, this is gone. My screen is gone again. Again, not sure.
So
what's going on.
screen is there, but the slides are not changing.
Yeah. Because what's happening
So
is
if
the
you
minute I change, all the videos, what I'm doing is the minute I minimize all the videos, I think the screen is going away.
Sir, is it possible for you to share the slide on WhatsApp? We'll do the
I'll
sharing
do
for
it
you.
right away. I'll do it right away. Just a second.
So either WhatsApp or you can also attach it in the here also, sir.
Yeah, मैं कर देता हूँ.
We can see your slides.
It's just not moving. This is something very, very unusual. Okay, 1 second.
Ashish, you can guide sir on
Yeah,
how
yeah.
to share.
Yeah, 1 second. Yeah. Let's do a last chance. Yeah, last chance. I think it should work. Last chance. Yeah. Can you see me? Are my slides visible? No.
Slides are visible, sir.
but not moving. Okay, I attach it. I attach it to you. Yeah, मैं attach करके भेजता हूँ आपको.
Ashish,
इसमें
you
कहाँ है?
can just
Where is it?
guide.
Sorry, I go into more. Correct? No.
Yeah. So Ashish, how can sir send the slides over chat?
सर आपकी स्लाइड्स का जो पीपीटी बना हुआ है उसका साइज क्या रहेगा सर? तो वो आप व्हाट्सएप पे शेयर कर पाओगे आसानी से, जो अगर
ये लैपटॉप पे नहीं.
एमबी
अरे
में रहे.
भाई, अरे भाई, this is my presentation laptop. It is.
ओके
If you want, I will email it to you. Just a second. But
ओके, यस
email पे
सर.
नहीं जाएगा. ये email पे नहीं जाएगा. email पे नहीं जाएगा. Can I just log in again? Yeah, I just log out and log in again. Yeah.
Sure, sir.
So the same thing was happened with me also. I could not able to move to the second slide only. So I use my hands to.
Ashish, he will not be able to share his slides over chat.
नो सर,
Dr. Manish, you can take it over your
Because,
WhatsApp, na?
Ah, he's joined.
slides PPT is too heavy, so that's why they.
Yes, sir, it's moving also now.
Okay, it works. Okay, it
Yeah.
works. All right. Yeah. So this is a case of a 58-year-old woman who presented to a pulmonologist with a high-grade fever and cough for almost 1 month duration. Now, this is a representative case. Okay. Now, this is a 58-year-old woman. She was weighing 75 kilos. She's a known case of diabetes and hypertension presenting to a pulmonologist. So yes, a young lady with comorbidities, and she is overweight. Her complaints have been a high-grade fever and cough on and off for approximately 1 month. Previous admission at a private hospital with no relief, and investigations performed were CBC, chest radiography, bronchoscopy. Blood test shows leukocytosis. Now, the chest X-ray is suggestive of a lobar pneumonia. So what do you see here? You see here this X-ray chest, and in the mid on the right side, in the mid zone and the lower zone, you can see that there is a haziness here. So there's a dense homogeneous opacity in the right lower lobe with relatively sharp borders, which correspond to a consolidation typical of a lobar pneumonia. Within the area, we see air bronchograms. Now, this is air bronchogram is a common. So, if there is an opacity, and if there is an opacity which is having any air bronchogram, that means you can see the bronchi within the opacity. That is a classical thing for pneumonias. The lung field outside this area appear relatively clear. So if you see here, this is the opacity where my cursor is, and the rest of the lung area is pretty clear here. Okay, so this is a description of a lobar pneumonia. Sometimes you can have a multi-lobar pneumonia. You can have a pneumonia in upper part, lower part of the lung. Sometimes you can have a patchy pneumonia. Okay, so there are various patches, and that can be called as a patchy consolidation. There's no pleural effusion that is seen because the CP angles, that's the costophrenic angles that are seen on these X-ray are quite sharp. The cardiac cell and the mediastinum appear normal, and ruling out any cardiomegaly. So sometimes if there is an associated pericardial effusion, you may see a cardiomegaly may be seen. Sometimes if there is a mediastinal widening meaning that a mediastinal widening represents a enlargement of the mediastinal lymph nodes. There could be the paratracheal lymph nodes, the subcarinal lymph nodes, etc. So all that thing is not there. So this is just a right mid-zone, lower zone opacity, which has got air bronchograms, suggestive of a lobar pneumonia. And it's not a completely lobar pneumonia, it's a partial lobar pneumonia. The previous treatments which this patient has taken are IV amoxicillin clavulanate plus levofloxacin with no improvement. That's very interesting because typically these are also very good antibiotics which are used in practice. So unless there is some form of resistance, etc., yeah, these may not work. She was shipped to piperacillin tazobactam also plus levofloxacin for 5 days. That also did not show any improvement. Now, having said that, these are typical antibiotics which are also used in the treatment of lower respiratory infections, and often you would have a improvement, except when there is a resistance in the pattern. Sometimes there are resistant bugs also. So if a patient has picked up a resistant bug from somebody else, then that's where you can get these type of patterns where you don't have response to these therapies. Empiric anti-TB treatment was also started without conclusive evidence, and this is something which is strongly discouraged. One of the things that is strongly discouraged in this prescription that you see here is the use of levofloxacin for a community-acquired pneumonia. At the most, if any point one has to think about an an atypical cover, a macrolide is the preferred agent rather than a levofloxacin or a quinolone, because quinolones are clearly reserved as anti-TB drugs in our country. Okay, so one thing is clear: we should not consider to use levofloxacin routinely, empirically in management of lower respiratory infections. There are conditions when you can use levofloxacin or a ciprofloxacin. That is, if you have a proven pseudomonal infection, if you have a pseudomonal infection which has been shown to be sensitive to levofloxacin or ciprofloxacin. In that case, we know that there is no misdiagnosis. The diagnosis is typically based on cultures reports, and that's where, in a non-TB situation, I typically land up using a ciprofloxacin or a levofloxacin. And of course, the empiric anti-TB treatment considered, this is an old practice. So in the current era, we should not consider empiric anti-TB treatment unless we have got a sputum test which shows a NAT or a TB gene expert, which is a positive NAT is a nuclear amplification test, which is positive, or a gene expert, which is positive, or a culture, which is positive, or you have a histopathology, which is showing suggestive of a tuberculous finding, such as a caseating granulomatous lesion. On examination at the coronary, she is well built, conscious, she's febrile at 100 degrees Fahrenheit, productive cough with frequent expectoration, a pulse of 78 per minute, blood pressure is normal, so there's no hypertension or anything, seems to be a very hemodynamically stable patient, no pallor or adenopathy. When we say lymphadenopathy, we typically are examining the neck lymph nodes or the axillary lymph nodes. Cardiovascular and the central nervous systems were normal. Breath sounds, they were diminished bilaterally, and there were some crepitations in the right lower zone. So sometimes, the common finding in patients who have the common finding in patients with a pneumonia, if you have an air bronchogram, you can get a bronchial breath sounds. But sometimes the bronchial breath sounds may not be appreciated well, and therefore you may sometimes also get the crepitations. Now, the diagnostic and the treatment plan at present, empiric anti-TB and antibiotic use is typically successful in most cases. Like I told you earlier, I think amoxicillin, clavulanic acid, and levofloxacin, although discouraged in our country, is a very good combination to treat a low respiratory infection. In the West, where the TB is not a big problem, I think quinolones are, if you look at the infectious disease guidelines, quinolones also come up with the initial treatment. So now, and typically in high risk individuals, as elderly people who have comorbidities, immunocompromised, transplant recipients. Now this patient is diabetic. Okay, a detailed investigation must be done. So typically, if you have a patient who has been unwell for a month, we need to do certain investigations. Neoquinolones are avoided in the early phase of treatment when other effective antibiotics are available. And I already discussed with you when the levofloxacin or a ciprofloxacin or a moxifloxacin should be reserved only for typically anti-TB treatment or atypical mycobacterium, etc. Now, a bronchoscopy and a bronchial lavage was performed. Now, just to add some flavor to this, I'll let you show on the next slide. I hope the video plays, and then this shows how a bronchoalveolar lavage is performed. So, what is being done here is this bronchoscopy, the bronchoscope has been has passed into the area. You see the bronchi. This is the underwater. So you wedge the bronchoscope into the airway. We instill saline into this particular segment wherever on the CT. The CT scan is the guide. The CT scan tells us where we would go and put the bronchoscope into the and do a lavage, or if it's very apparent on the X-ray chest. So basically, a chest imaging guides us to the site from where a bronchoalveolar lavage is done. What you see here is saline, which is instilled, and again it is sucked back. So what the saline does is it washes that particular area, and that area, that this is extremely important. The reason I put this video up here is to just put it across. A simple test that takes about 10 minutes or 5 to 10 minutes is an opportunity for us to do a detailed investigation and allow us to get to a precise diagnosis. So a bronchoscopy and a bronchial lavage was performed for this patient. Then again, the samples have gram staining, which is important. AFB testing, that is AFB, that acid-fast bacilli. That's what you sent for. And then microbiological tests are sent, antibiotic sensitivity test, there's the aerobic culture. But the AFB testing now is no longer limited only to the smears. It is also for to set for molecular tests. So my molecular test, which is sent and you get within a few hours in most places, if not few hours, the next day is a TB gene expert, and that's important for a rapid diagnosis of TB. Microbiological cultures in this situation would include an aerobic culture, but because you've done a bronchoscopy, you also want to send it for TB and want to confirm, because somebody thought of giving empiric anti-TB treatment that clearly needs to be stopped in this case. You send the samples for testing and try to get a confirmed diagnosis. This patient was stable and was being managed on an outpatient basis, was treated symptomatically with cough suppressants and paracetamol. I already showed this to you. So what about the microbiological findings? Acid-fast bacilli were negative, probably gene expert was also negative. Gram-negative organism was seen on gram stain, and the culture sensitivity eventually revealed Klebsiella pneumoniae, resistant to multiple antibiotics and sensitive to cefuroxime. And we see this from time to time. Okay, so clearly the antibiotics that were offered to the patient initially, unfortunately, the patient was, despite being good choices, patient was not sensitive probably to those antibiotics, and here we come up with cefuroxime. Now, this patient was initiated with oral cefuroxime, 500 milligram twice a day. This is chosen because of the sensitivity, the gram-negative, it's a gram-negative bug, and it has a broad pathogenic coverage and a strong efficacy, and is used as an important treatment in the important molecule in the management of community-acquired pneumonia or a lower respiratory tract infection. Clinical outcome, this patient improved remarkably, completed the 2-week course of cefuroxime. A slightly longer duration can be given. Now, the duration of the antibiotic is interesting. If we're doing empirically, yes, you can give for, longer duration. And now you've got molecular biomarkers. These biomarkers can also help you to limit the duration of antibiotic therapies. You can do CRPs, CRP trends can be seen, and if you've got a downward trend, normal becoming CRPs, patient clinically better, you may consider to restrict the duration of antibiotics. And sometimes, and a more efficient but slightly more expensive test is the procalcitonin. Procalcitonin has also been shown to initiate an important biomarker to initiate antibiotic therapy in patients with the suspected infections. And at the same time, if you've received this given adequate antibiotic therapy, you're deciding about prolonged antibiotic therapy, if you do a procalcitonin that is negative, you can safely stop the antibiotics here. Now, if you look at this X-ray chest, the lung fields appear, are clear bilaterally. The opacity that was seen in the right lower zone is no longer visible. Clearly, you can see both the lung volumes are fine, the vascular markings are fine, the diaphragm contour is fine. There's no suggestion of a pleural effusion, and the heart size also seems to be normal. So basically, if you see this X-ray chest is almost a near normal X-ray chest. So this can be classified as a remarkable improvement from the infection, because clinically the patient has improved, and the X-ray chest has also shown a remarkable improvement or regression of the opacity. So with this particular case in the background, let's move to the discussion aspect now. And we are going to keep it very, very simple. We don't have very complex slides. Yeah, we are going to restrict ourselves to the practical approach to the management of lower respiratory infections and also to pneumonia. So, what is a lower respiratory illness? An acute illness present for less than 21 days. Cough is the predominant symptom in these patients. At least one additional lower respiratory tract symptom is present in these patients, such as sputum production, breathlessness, wheeze, chest discomfort, or pain. So this is what represents a lower respiratory infection. Now comes the question: is you need to ask the patient history for any sinusitis, asthma, because sometimes even an asthma flare-up can give you sputum, can give you breathlessness, can give you wheeze, can give you chest discomfort. Therefore, all these symptoms need to be considered in a particular clinical setting. Now, what are the spectrums of lower respiratory infections? It's very easy for us to put a cough, purulent sputum, fever as an LRTI, but we can further classify them into an acute bronchitis. You can have a pneumonia, like you saw earlier, that's a low respiratory infection. And then you can have an exacerbation of a chronic lung disease. A patient with asthma can also get LRTI and can exacerbate the asthma. Somebody with COPD can get an LRTI and cause a flare-up of the COPD. A patient with bronchiectasis can also get a fresh infection, and that can cause, again, a low respiratory infection. And often these people with a chronic lung disease will come up with symptoms or increased symptoms of the underlying lung condition. Now we talk about lobar pneumonia. Lobar pneumonia is an acute lower respiratory infection with consolidation of a large continuous lung lobe due to alveolar inflammation exudate. What happens in a lobar pneumonia? Whenever there's a lower respiratory infections, then there is, if that is quite severe, that clearly there is a alveolar inflammation. There are secretions, exudate formations, and this solidifies. So pneumonia is also a consolidation. So what does the consolidation mean? The lungs some sort of solidified. Lung otherwise is like a sponge. Because of the infective exudate and the inflammation, the lung becomes solid, and therefore it's called as a consolidation. Also, so lobar pneumonia or a lobar consolidation both mean the same thing. There are several processes pathologically or which the lung undergoes in case of a pneumonia. There is a congestive phase, then there is a red hepatization, where you have a lot of inflammation in the RBCs. That's gray hepatization, and then the next step is the resolution. So these are the stages of the pneumonia, pathological stages of pneumonia, and the radiological hallmark is a lobar consolidation on a chest X-ray. Okay. What are the clinical presentations that one may get? One is symptoms of fever, productive cough. These are the breathlessness, chest pain, headaches, body aches. These are all the symptoms that an individual with a lobar pneumonia can have. These patients can also have breathlessness. So, so these are the symptoms to watch for, or whenever these symptoms are there, one has to consider a lower respiratory infection. You need to examine the patient. If you've got a bronchial breath sound, that really confirms the diagnosis of a consolidation. Now, what are the bugs which can cause the lobar pneumonia? Streptococcus pneumonia is the most common. Klebsiella pneumonia is there. Legionella pneumophila is there. Haemophilus influenza and MTB. These are the common pathogens which cause lung infections in our country. Now, which are the risk factors for LRTIs? Why somebody should get a LRTI and somebody else should not get a LRTI? Advanced age, we know that with advanced age, there's a reduction in immunity. Male gender, maybe they're more outgoing, working, meeting more people, maybe. Yeah. Chronic bronchitis, that is an Indian, that means there's a risk factor. Somebody who has a COPD is also a risk factor. Presence of comorbidities. Our patient had diabetes. We know that diabetes increases the risk of infections. Then also you can have renal problems. You can have any other way. You can have an underlying malignancy. You can have an underlying, autoimmune disease. You may be on immunosuppressive medications. All these factors increase the risk of a lower respiratory infection. Then you have smoking. Smoking clearly reduces the lung immunity, causes bronchitis, is a cause of COPD, and in individuals who have a history of smoking or have bronchitis, COPD, they are likely to have more symptoms, more worsened representation of the respiratory infection. Now, from a global perspective, LRTI remains a major public health challenge, contributing significantly to the morbidity and the mortality across all age groups. I had several charts. We've restricted ourselves these charts so as to keep the discussion simple. The WHO says that LRTIs, that's the lower respiratory infections, are the fourth leading cause of death from communicable diseases, is the second cause of disability worldwide. LRTIs are responsible for approximately 2.74 million deaths. That's almost 27 lakh people die because of a lower respiratory infection. From an Indian perspective, it contributes heavily to the disease burden. It's, all these things, about increased, daily adjusted life years of there's a disparity, there's an increased risk of infections. But I suspect, a lot of effort has been put into getting the correct numbers for India. But I still think that these are likely to be underestimated. All of you, I'm sure, will agree that low respiratory tract infection is very common, and I think we really are in a situation where we need large studies to identify the burden of the disease. Now I've put forward you this curb 65 criteria, and then these are indices which are used to guide the community acquired pneumonia management decisions. Say, for what is the curb 65? C stands for confusion, okay? Then you have R, which stands for a respiratory rate. B stands for blood pressure, and 65 stands for the age. In the past, urea also used to have an important value, but this is what we will say. Now you give 1 point. Is the patient confused? Is the patient tachypnic? Is the patient hypotensive? Is the individual 65 years or more? If there's no confusion, there's no tachypnea, there's no hypotension, patients less than 65 years of age, the risk category becomes lower risk of mortality, and therefore outpatient treatment can be given to these patients. If you have one of these criteria present, such as age more than 65 years of age, you have hypotension or respiratory rate which is tachypnic, more than 30, confusion, then you may need to hospitalize the patient, okay? If you have a score of 1 or 2. If you have a score of 3 or 4, the likelihood of mortality increases remarkably, okay? The mortality percentage is very high, and one should strongly consider hospitalization of these patients. So I just put this slide up just to have give a more practical perspective of how we decide about outpatient management, who is on the fence and who definitely needs to be hospitalized. So these are these are again the tools which one need to look at. You have the minor criteria, you have the major criterias, and basically these criteria, forget scoring them. what you really need to understand is whenever we are seeing a patient with pneumonia, you should see if there's a tachypnea. If he's ventilated, then you need to see whether the PO2 FiO2 ratio is less than 250. Then you have a multi-lobar infiltrates. I said, you can have our patient is just a lobar infiltrate. You can have multiple lobes which are involved. You can have a patchy consolidation all across in a single lung or both the lungs. Uremia is something very, as I was telling you, confusion is something that you need to look at. Uremia is something that you need to look at. Then you have a leukopenia. If there's leukopenia, I think that can represent bone marrow suppression, or it can be in a severe viral infection. Also, you can have leukopenia. But in a setting of a bacterial infection, if you have leukopenia, that's not good, because typically you would expect a leukocytosis. You would expect the WBC counts to be on the higher side. Okay, again, so basically a reduction in the WBC count, platelet counts, all these things factor towards bone marrow suppression, and that can be typically seen in a severe infection. All these factors you need to really look at just to decide whether, to give you a clinical idea whom you should treat, again, on an outpatient basis, definitely on an inpatient basis, and there'll be some in the middle where you need to take a clinical call. Now, the role ceftriaxone remains an important antibiotic place in management of community-acquired infections in Indian real-life settings. A review of scientific evidence has concluded is an appropriate empiric choice for respiratory infections and also the urinary tract infections. Our urology colleagues use ceftriaxone a lot. Skin and soft tissue infections on an outpatient basis. And what is the idea of using ceftriaxone or other regular simple antibiotics is you want to treat most of the sensitive patients appropriately with these antibiotics, and the higher antibiotics need to be reserved. Otherwise resistance is a problem. All of us come across resistance problems, and particularly we have so many cases of primary resistance also. Now, if you look at the guideline recommendations, the doses recommended is 500 milligram twice a day on an outpatient basis for CAP patients with comorbidities. That could be a lung problem, could be a heart comorbidity, renal, diabetes, alcoholism, malignancy. I discussed with you that these are the comorbidities, and they say that ceftriaxone can be considered in this case. The ICMR endorses ceftriaxone for the outpatient treatment of community-acquired pneumonia in individuals with and without antibiotics. The dosage is 500 milligram twice a day or 1.5 gram of IV twice daily. A question that is typically asked for me is, Doc, why is the IV dose higher than the oral dose? Because IV goes directly to the blood, peak levels immediately are achieved. The oral don't have to go undergo any absorptions, etc. The idea is that if you're going to use IV therapy, that means the patient is going to be having a more serious infection, and that's the reason why you need to give a higher dose. This is a multi-center study across 18 centers. There was 274 patients with lrti. The treatment regimen was ceftriaxone 750 milligram intramuscularly every 8 hours. Okay, now if you look at in this particular study, if you look at the clinical outcomes, there were bronchopneumonia patients, 105 patients, 90% patients success rate. There were post-operatively pneumonia, 91% success rate. We know surgeons also like to use ceftriaxone post-operatively in the appropriate clinical situations. Acute exacerbation of chronic bronchitis, 89% success rate. So here we are seeing a near almost 90% success rate in the particular clinical settings. Renal function is monitored closely throughout the therapies, the study conclusion was that ceftriaxone 750 IM is every 8 hours is effective for treating lower respiratory infections, and it's got a high efficacy and a favorable safety profile. Now, ceftriaxone and ceftriaxone exetil versus amoxicillin plus clavulanic acid in the treatment of lower respiratory infection. This was a multinational, non-blinded trial in 512 hospitalized LRTI patients. The treatment arms were ceftriaxone IV 3 times a day, followed by 500 milligram twice a day. And that was for the cefuroxime thing. And for the amoxicillin, you had 1.2 gram IV 3 times a day. And these patients will, after 40 to 72 hours, were switched to 625 milligram oral therapy. So 2 to 3 days of IV therapy, and the same drug is given orally after that. If you look at the clinical response, 87 improved with the cefuroxime, amoxi 85.9%. Bacteriological clearance, cefuroxime 72%, amoxiclav 70%. Conclusion, cefuroxime is an effective drug, and I think both are effective, that is amoxiclav and this, but this is an advantage of a twice daily regimen. Now, there is also this paper about the, if you look at this paper published a long time ago, 1995, it looked at the short course therapy 5 days with cefuroxime exital in treatment of secondary bacterial infections of acute bronchitis. So again, this is about for, acute bronchitis patients, having lrti multi-center randomized trial of more than 500 patients with secondary bacterial infections of acute bronchitis. So here a small dose was used, was 250 milligram twice a day of cefuroxime exital twice a day, and then amoxiclav used for 500 3 times a day for 10 days. The cefuroxime arm, 5 days, 82% recovery. In a 10-day cefuroxime arm, there was an 86% recovery. Amoxiclav, there was an 83% recovery. Higher rate of drug-related adverse events was seen with amoxiclav, and conclusion was cefuroxime is effective, well tolerated with shorter 5-day therapy, performing comparable to 10-day regimens. What is my choice? I typically land up writing 500 milligram twice a day. Maybe I see more severe infections, and I think for me that really works very, very well. Cefuroxime and ampicillin compared in a double-blind study in the treatment of lower respiratory tract infections. So this is a randomized double-blind trial comparing cefuroxime and ampicillin. If you look at the participants, 57 received cefuroxime, 750 milligram intramuscular 3 times a day, and others, 54 received ampicillin, 500 milligram intramuscular 3 times a day, and the duration of treatment was 7 to 10 days. Whenever they say 7 to 10 days, that means the treating physician decides when the treatment needs to be stopped or continued for 10 days. All patients had acute exacerbation of chronic bronchitis plus minus pneumonia. Excuse me. Some had bronchiectasis, and around 25% underlying bronchial carcinoma. Mucoid conversion was seen in 87% of patients with cefuroxime compared to 48.1% patients with ampicillin. When you say mucoid conversion means a purulent sputum turning out to be non-purulent. Satisfactory outcome was seen in 94.7% patients with cefuroxime versus 68.5% with ampicillin, and both efficacy endpoints favor the use of cefuroxime. If you see that, this paper is very old, 1980. I hardly use ampicillin, in my regular day-to-day outpatient practice. So what are the key notes here? The key notes are community-acquired pneumonia is a leading cause of morbidity and mortality in elderly patients. Elderly patients often present atypically with chest infiltrate, sometimes unaccompanied by fever or leukocytosis. We need to investigate the patients appropriately to make the proper diagnosis. And the antimicrobial therapy must consider both adequate pathogen coverage and patients' renal and hepatic profiles. Hospitalized patients benefit from parenteral therapy for rapid achievement of therapeutic drug concentrations, followed by oral therapy. Inappropriate and injudicious use of antibiotics contributes to drug resistance, rising resistance, and hence culture-sensitive testing therapy should be done wherever it is required and whenever it is possible. Empiric antibiotic is often necessary, but in high-risk individuals, please see here, the high-risk individuals, elderly, immunocompromised, transplant, our diabetic patients, a detailed investigation is important. I mean, what you can do is just, yes, patient comes to you, you can't wait for 2 days until you get the aerobic culture reports. You start the antibiotic, initiate the antibiotic treatment, start treating the patient, get the sputum cultures, and if the sputum cultures comes and you need to modify the treatment, that can be coordinated with the patient. early use of neoquinolone should be avoided whenever safe and alternative medications are available. And again, I told you why we need to avoid the quinolones such as levofloxacin or ciprofloxacin or moxifloxacin in LRTI management, because they are reserved for TB treatment in our country. And now you will see we are going to get more and more guidelines. You've seen more guidelines which are also coming from CDC, WHO, and we might see moxifloxacin in the new regimen of the anti-TB treatment, and maybe representing ethambutol. Let's wait for the updated Indian version of the guidelines coming in, and you will see the important role that these quinolones play in our practice. Cefuroxime is a second generation cephalosporin. It is active against major cap pathogens and is available both in intravenous as well as oral forms, supporting seamless sequential therapy. It's just easier to convert somebody from the from an IV medication to the same molecule in oral. That's a big advantage for not only for cefuroxime but all other antibiotics, where you can just simply switch from intravenous to oral. It demonstrates a strong efficacy, favorable safety, and broad pathogen coverage, making it suitable for empiric treatment and also in elderly patients. But mind you, whenever given a chance, you should do a detailed clinical evaluation. I showed you clinically also one can suspect there are these criteria which can help you to decide the severity of the pneumonia or the lower respiratory infection based on the detailed clinical assessment. And that doesn't really take a lot of time. You just need to look at it and get an idea whether you're going to treat your pneumonia or the LRTI patients on an outpatient basis, or he definitely needs to be admitted, or he's somebody on the fence. You start them on oral treatment, and you very clearly explain to the patients, give them the guidelines on in which situations one may need to get hospitalized. Symptomatic treatments further aid in symptom relief and faster recovery. So I really hope that this was helpful for all of you. Thank you very much for this opportunity, and thank you very much for this patience hearing.
Thank you so much, sir. Your practical tips, your explanation, the short and crisp explanation, and the case-based discussion was truly enriching experience. And sir, we will now move forward for the question and answer session. So the first question the audience asks is, how do you differentiate between the community-acquired pneumonia and hospital-acquired pneumonia in your practice?
So, community-acquired pneumonia, clearly the patient has not been in the in the hospital. He's been at home. He's been at work. He's never been to a healthcare facility where you may be acquiring a particular exposure to a particular infection. When we talk about healthcare facility related infections, that's when an individual has been exposed to is in the hospital. Either you may be visiting the hospital or you may be admitted in the hospital, and you've developed the symptoms. I mean, say for example, you went for some other non-infective cause, and after 3 days you develop a fever. Then that's clearly either the cause may be either that whatever non-infective cause has an infective potential, or it's completely, say, a cardiac problem. You don't need a you don't expect an infection, but after a few days you develop an infection, then you can call it as a healthcare associated infection.
Okay. Thank you so much, sir. Now, second question, how to monitor bacteriological pneumonia and fungal pneumonia through radiograph? Is the lag in the symptoms and X-ray improvement same in both cases? Like, is it any differentiation between the symptoms of improvement in the symptoms that we can see on the X-ray between the fungal and the bacteriological pneumonia?
So, firstly, I just want to tell you all of you that yes, you can get bacterial pneumonia, you can get viral pneumonia, you can get fungal pneumonia, but fungal pneumonia is not so common. So
Okay.
please don't try to make a diagnosis of fungal pneumonia just based on an X-ray or a clinical assessment. For a fungal pneumonia, there has to be a reason why somebody would get a fungal pneumonia. Is that individual immunosuppressed? Is that individual got an autoimmune problem? Is the individual a transplant recipient? Does the individual have a morbidity which is not well controlled, such as a diabetes or a renal problem, which is so you need to really think about a fungal pneumonia. I'll tell you, I've hardly ever clinically on an X-ray diagnosed a fungal pneumonia. But
And
so you
uh,
need to let me finish. Yeah, let me
yeah,
finish. So in a fungal pneumonia, it's not a common diagnosis.
yeah.
Now, what if you made a diagnosis of fungal pneumonia? If you made a diagnosis of fungal pneumonia, and then I think whether it's a fungal pneumonia or it's a bacterial pneumonia, the clinical improvement is of paramount importance. If the patient is improving clinically, clearly we know that there can be a radiological lag. Often we see a radiological improvement within a couple, within a few weeks. But it is always said that if you really want to compare X-rays before and after, there should be at least a gap of 4 to 6 weeks before you compare. So that could be an X-ray or a chest imaging. So if a patient is stable, your patient has had a patch on the X-ray, you want to know whether that patch is cleared. Give that individual a fair amount of 4 to 6 weeks so that you are not doing unnecessary X-rays.
Thank you. So, extension to this question, sir, how can you differentiate radiologically between the typical pneumonia and the atypical one?
Very good.
Mm.
So there are some markers which can give you a guide whether this is a typical or atypical pneumonia. Now, what the X-ray you saw in this particular case, this is a classical typical. What does a typical pneumonia mean? A bacterial pneumonia. Okay. Atypical pneumonia, matlab kya? Atypical pneumonia, that means you're talking about the chlamydia, mycoplasma, legionella, all those sorts of pneumonias are atypical. There's nothing atypical about it, but they're just atypical bugs causing pneumonia. But so that's all about the word atypical. What can be the presentation? If you see an atypical pneumonia, typically you will see patchy opacities. You will not see a strong. Yeah, you can get a lobar consolidation with atypical pneumonia, but the common you can get a patchy consolidations. May not be restricted to one zone. You can have it in more than one zone. And now it's very clear. If you are dealing with an opacity on the X-ray chest. If it is a pneumonia, if it's a simple small patch, patient is stable, your S is fine. But I must tell you, a significant number of patients who come to you with an X-ray opacity of a pneumonia or an atypical pneumonia, you will need to do a CT scan of the chest. Now, atypical pneumonia and viral pneumonia can sometimes almost look quite similar, and that's where the role comes in your clinical assessment. Is there a viral wave going on? Are people at home unwell? You know, so if those can be the cues for you to suspect about a viral pneumonia. Yeah.
Okay. So now the question is related to our topic. Next question: how reliable is a chest X-ray in identifying the complications like pleural effusion, emphysema, or lung abscess in lrti cases?
Very good.
How? Yeah.
Yeah. So X-ray chest is fantastic. You saw that if you have an X-ray chest and if there's a patch, we do an X-ray, or even if a patient is admitted, we don't do a CT scan every few days. We may do an X-ray every few days because X-ray gives a good, reasonable assessment of whether that pneumonia patch is increasing, stable, or decreasing. What does a complicated pneumonia mean? A complicated means, say, for example, somebody has a pneumonia and that patient develops an effusion. That effusion is typically a mnemonic effusion. If patients are stable, one may decide not to, not to needle it, not to examine it. But if the fluid is increasing, if that's not settling down, if symptoms are getting worse, fever is persistent, then you really want to know, is this a mnemonic effusion or is this patient developing a empyema? So that's very important. So you again, X-ray just shows you that there is a collection of fluid there's a possible collection of fluid in the lung, and whether that needs to be investigated further, it really depends on the clinical assessment, how the patient is improving, and sometimes even your biomarkers such as a CRP or a PCT or a CRP trend for that matter, If you have a fluid in the lung, if CRP is going down, patient is going down, there's mild amount of an effusion, you may just want to observe them. Lastly, about your lung abscess. Lung abscess, clearly you have a pneumonia which is breaking down. Then you get an air fluid level. Then that's the diagnosis for a lung abscess. Typically, you may at some point, you get a CT chest done to assess the proper extent of the disease, but a lung abscess on a routine basis can definitely be monitored on X-ray chest. You have to look at the air fluid level. If the lung abscess is connecting to the bronchus, then they may be coughing out the sputum. If patient is responding to the therapy, then slowly that the lung patch may be shrinking also.
Sir, thank you, sir. Now the next question is now there is availability of CT scan. And what we found during the COVID also, doctor were directly using the CT scan directly for the diagnosis or for the patient improvement. Does still the X-ray hold the irreplaceable role in the LRTI evaluation and management? And when do you place X-ray and when you place this CT scan in this patient?
So I will just to let you know, when to do a CT scan. I think every cough, cold, fever does not need a CT scan. Okay. Whenever a patient is come to cough, cold, typically most of our colleagues will be treating it, and myself will treat it on a. Every empiric is sometimes a harsh word. You treat it based on a clinical assessment, an empiric maybe. If patient has got comorbidities, if the patient is coming to you with the symptoms of last several weeks or a few days, has taken therapy and is not improving, and you find some signs on the x-ray, you see on examination, you see an x-ray chest and there's some opacities which are not definite, then yes, you must do a CT scan at that point. Okay. And I think the CT scan, if you're not sure whether it's a lobar pneumonia or if there is a multi-lobar pneumonia, or if there is a patchy consolidation, which could be an atypical pneumonia or a viral pneumonia, in that case also a CT scan is important. And having said this, now the accessibility of CT scan in our country is reasonably better,
Yeah.
particularly after COVID, than what it was before. Now, its whole idea is about the cost efficacy. One can argue and say it is very expensive, but in the given patient, if your patient has got a comorbidity, if he's a high risk individual, he's at low immunity, he's a transplant patient or autoimmune disease, whatever it is, and in those patients, you really want to know that, often, not always, you want to know that, yes, I may, sorry, yeah, may want to know that uh, what is the extent of the disease, you get it. Secondly, if there's a reason why you need to do a bronchoscopy for a patient, now just typically, often if you want to do a bronchoscopy invasive procedure, you need to do a CT scan. If there's a complicated pneumonia such as a pleural effusion which is getting up, you suspect the heart is enlarged, there can be an effusion, then you must do a CT scan and see. So I think a CT scan should not be delayed. It should be done appropriately, because the CT scan will often allow you to, choose, it will help you to get onto the proper treatment pathway.
Okay. Thank you so much, sir. Sir, can we take one or two questions or?
I think that the call is already coming.
Yeah,
That I must join on another con
yeah.
call.
So
Yeah, if you don't mind. Yeah.
we have already covered a lot of questions, sir.
Yes.
And in the
Yes.
topic also, you are in the session, you have covered all the questions and with on the behalf of our organizing team, Alkem team, we extend our thanks to Dr. Prashant sir for delivering such a insightful session, and also thanks to all the participants who have asked the question during the session. And we look forward for such engaging session in upcoming webinars. Thank you so much, sir, and thank you all the audience. Yeah.
Thanks a lot, sir. Just to inform you, sir, where we were around 400 plus people live for
Okay.
this session now,
Thank you.
and we went up to 2,800 registration for the event. We'll be sharing this recording across for the valuable insert. And Curve 65 was superb, sir. Thank you. Thank you for the time, sir. Thank you for the talk.
Thank you. Thank you so much.
Ish, we can stop the stream here.